Peripheral neuropathy is a disorder mostly resulting from damage to the peripheral nerves, motor, sensory, or autonomic, or mixed. Motor, sensory, autonomic, or mixed, leading to weakness, sensory loss, autonomic dysfunction, or pain, either slightly singly or in combination. So, peripheral neuropathy means damage to the motor nerves, sensory nerves, autonomic nerves, or a mixed disorder with weakness, sensory loss, weakness because of motor, sensory loss because of sensory, autonomic dysfunction because of the autonomic. Okay, or pain or slicing, pain may be there. Pain also is disturbed or more. It may be two-way. Maybe positive increased pain sensation or a negative absence of pain, singly or in combination with others. Most important thing is there is no CNS pathology. Peripheral neuritis means you should exclude CNS pathology. No hemiplegia, no other cord involvement, no brain involvement. It is not a neuromuscular junction disorder also, like myasthenia gravis or something. And it's not a primary muscle disease also. So involvement of the sensory, motor, and then autonomic in the absence of central nervous system involvement, cord involvement, NM junction involvement, and primary muscle weakness. So that is the most important definition. Then the functional classification. What fibers are involved? Generally, this is very important. You may not notice. Sensory neuropathy versus motor neuropathy. Sensory symptoms can be positive symptoms like pain, paresthesias, burning, and electric shocks. These are called the positive sensory symptoms. Pain, paresthesias, burning, and electric shock. And negative symptoms are numbness, loss of vibration, and proprioception. Often the earliest manifestation will be the sensory neuropathy. Then motor. Weakness, usually distal weakness is more in peripheral neuropathy than proximal weakness. In case of myopathies, usually proximals are affected. In case of spinal cord involvement, proximals are more affected. Peripheral neuropathy, distal is more affected. Distal means these things. Proximal means the shoulders. So what do you find? Because it is a nerve involvement, you will find weakness, you will find wasting, you may find fasciculations, you may find reduced reflexes also. Because it is the lower motor part of the tract, isn't it? Autonomic neuropathy. Autonomic neuropathy means postural hypotension, erectile dysfunction, bladder and bowel dysregulation, and abnormal sweating. Gastroparesis also, particularly diabetic gastroparesis, is a known autonomic neuropathy. That is, gastric motility is reduced and you will have dysmotility symptoms. Mixed sensory motor neuropathy. That means both sensory and motor are affected. Usually the common cause of mixed neuropathy is diabetic neuropathy. The common cause is diabetic neuropathy is the common cause of mixed neuropathy. Then anatomical classification. We are going one by one. So we started with the definition. Then we went to the fiber-wise. We have said motor or sensory. That is functional classification. Then we are going to anatomical classifications. Mononeuropathy. Single nerve only is affected. And for example, medial nerve carpal syndrome, or you may have Saturday night paralysis, radial nerve paralysis due to Saturday night. Suppose somebody sleeps like this on the radial nerve. Next morning, the wrist drop. That is called the Saturday night paralysis. And then mononeuritis multiplex. That means multiple individual nerves are affected asymmetrically. Each is individual nerve involvement only, but multiple nerve involvement is usually seen. Particularly, this affects in leprosy. You can see, Hansen's. You will have, multiple individual mononeuritis will be there. So he will have anesthesia and all the things in various areas. Such as vasculitis also, example, periarterid synodosia, general paralysis of Insane, SLE, that is systemic lupus erythematosus. Then, so what are the three types? One is mononeuropathy, the other is multiplex mononeuritis, and third one is a polyneuropathy. That means symmetric, long dependent involvement, length dependent involvement, and glove and stocking type of anesthesia will be there. Commonest presentation is a polyneuropathy. Mononeuropathy, multiplex neuropathy, that is multiple single nerves are involved, mononeuritis multiplex, or polyneuropathy. Okay. Now, we have got pathological classification. Understanding why the cellular level determinants in the clinical and electrophysiological, that is nerve conduction studies and EMG findings. So now, so we have seen the functional classification and then the anatomical classification, and we are seeing the pathological classification. Wallerian degeneration. That means distal degeneration following the focal axonal injury. Suppose the axon is going, axon is injured, distal degeneration. This is called the Wallerian degeneration. Proximal regeneration is very slow, 1 millimeter per day it will. So slowly none. Axonal degeneration. Axonal degeneration, metabolic or toxic failure of the entire neuron, toxic failure of the entire neuron, wherein dying back neuropathy is here. I'll show you what is dying back. So it is length dependent, starts in the toes, moves up. So first the toes are affected, then the ankles, then the knee joint, then up like that it goes, it dies backward. The neuropathy recovers in the first affected part, and slowly it progresses upward. This is a common pattern in diabetes and toxins. This is called axonal degeneration. Wallerian degeneration, axonal degeneration, and you have got the segmental demyelination. Segmental demyelination, damage to the Schwann cells or the myelin sheath. So first one is a Wallerian degeneration, axon is interfered, peripheral degeneration. Second one is axonal degeneration. Third one is demyelination. That means segmental demyelination. The Schwann cells are affected or the myelin sheath is affected. This is not length dependent. It can affect any segment. High risk of conduction block will be there, and you will see the EIDP, autoimmune the polyneuropathy or chronic immune polyneuropathy, CIDP, will come. Now we have fiber type of involvement. What type of fiber is involved? So the clinical presentation depends upon which fiber within the nerve bundle are hit hardest. Okay, large fiber involvement. Large fibers convey the vibration sense, joint sense, position sense, and deep tendon reflexes. Naturally, he will develop ataxia because of the loss of position sense and loss of vibration sense, and DTRs are also affected. DTR is what? DTR is nothing but a proprioception. It is stretch, that's why DTRs are affected in large fiber involvement. What are the causes of large fiber involvement? One is the B12 deficiency, other is diabetes. And CIDP is the chronic inflammatory demyelinating polyneuropathy, large fiber involvement. And small fiber neuropathies. Small fibers carry the pain and temperature. So lots of pain and temperature sensation is predominant here, presents with burning or electric shock-like sensations. DTRs are preserved. Why? DTRs are mediated by the proprioception and not by the pain and temperature. So here in small fiber neuropathy, tendon jerks are preserved. If you have neuropathy, the tendon jerks lost, it is related to the large fiber. If you have neuropathy, pain and temperature affected, dysesthesia, electric shock-like sensations, tendon jerks are preserved, it is small fiber neuropathy. If you have a case, they will definitely ask you, do you think it is small fiber or large fiber? How do I distinguish? Depending on, these are positive sensory symptoms, DTRs are preserved. Burning pain, hyperalgesia, allodynia, what is allodynia? Even a shirt falls on that, he will feel. Normally, whatever sensation is not eliciting pain, that produces pain. So somebody takes, if you put a towel, that is allodynia. So excessive pain perception for touch. Touch will be felt as pain. So that is allodynia. Normal vibration and proprioception reflexes are preserved. Initially, normal nerve remember, small fiber neuropathy, normal nerve conduction study. If you do a NCS, you don't get anything. They report normal, small fiber neuropathy. Causes are diabetes, amyloidosis, Fabry's disease, HIV neuropathy. Motor fiber involvement. Suppose motor fibers are in, then wasting will be there, weakness, fasciculation. Autonomic, orthostatic hypotension, gastroparesis, and then anhidrosis, and then erectile dysfunction will be there. Now we are coming to pathophysiological classification. How many types I am showing? functional classification, anatomical classification, fibrotype of classification, pathophysiological classification. Pathophysiological classification. So, we are discussing peripheral neuropathy. So, okay, pathophysiological classifications are, is it axonal neuropathy? Where is the pathology? If it is primarily in the axon, distal muscles are more affected than the proximal muscles. Muscle wasting is prominent. Nerve conduction studies, whenever you do NCS, you have to look at two things. They may even not know how to read it. Learn how to read an NCS report. NCS will have amplitude and conduction velocity. CV is the velocity. That is from here to here, how much time the impulse took to travel. That is the conduction velocity. And what is the impulse peak? That is called the amplitude. Amplitude and conduction velocity are two factors which should be studied. When you have simple neuropathy, like small fiber neuropathy, NCS studies are normal. Supposing you have axonal neuropathy, NCS, the amplitude is decreased, but velocity remains constant. Okay, the peak is decreased, but the time to travel the distance is constant, is not affected, relatively normal. Common causes are diabetes, alcoholic neuropathy, uremic neuropathy, and toxic neuropathy, particularly post-chemotherapy neuropathy. Post-chemotherapy, many people complain of neuropathy. That is because of the radiation toxicity. Then you have got the nutritional deficiencies, like beriberi or other B complex deficiencies, pyridoxine deficiency. These are all the nutritional neuropathies. So, what is the feature of nutritional neuropathy? It is an axonal neuropathy. Primary damage to the axons. Distal are more affected than the proximal. Muscle wasting may be prominent. NCS amplitude is reduced, but conduction is normal. Common causes are diabetes, alcohol, uremia, toxins, nutrition. The second one is, first this axonal approach. Now I am telling about the demyelinating neuropathy, where the axon is all right, but its cover is damaged. Something like electric wire, there will be inner copper core and outer plastic. The plastic is the demyelination. Plastic is damaged, so that is demyelination. But the core is all right. Core is the wire there, the core wire, the plastic inside copper wire. So demyelinating neuropathy, primary damage is to the myelin sheath. Weakness is more than the sensory loss. Okay, this proximal and distal both are affected with this. Reflexes are lost early when there is a demyelinating disease. NCS here, there is a decrease in the conduction velocity. There may be conduction block also. The conduction may be totally absent and conduction velocity is decreased. Whereas in case of axonal neuropathy, conduction is normal, but amplitude only is decreased. Okay, common causes. Guillain-Barré, acute inflammatory demyelinating polyneuropathy. AIDP is acute inflammatory demyelinating polyneuropathy. CIDP is chronic inflammatory demyelinating polyneuropathy. Guillain-Barré and CIDP can be differentiated based on the duration. Something is 2 weeks, 3 weeks, 4 weeks. It is Guillain-Barré. If it is long duration, it is CIDP. Hereditary demyelinating neuropathies, CMT. And I used to have one patient who has got a hereditary demyelinating neuropathy, HSN it is called. So hypersensory neuropathy. It's there, very sort of crippling disease. So HSN, hereditary demyelinating neuropathies. Temporal profile, that is time duration. Acute neuropathy, less than 4 weeks, usually. Guillain-Barré, porphyria, diphtheritic neuropathy. Subacute, weeks to months, CIDP, that is chronic inflammatory demyelinating polyneuropathy, nutritional deficiencies, and toxins. Chronic neuropathy, months or years, diabetes, alcohol, hereditary neuropathies. These are all very chronic. So, is it acute or subacute or chronic? Acute, you have to consider. Guillain, that one patient says, sir, I'm all right 2 weeks back, 3 weeks back. Only last 2-3 weeks I have got this. You have to think of porphyria, Guillain-Barré, and diphtheritic polyneuropathy. Somebody has got for weeks to months, nutritional, CIDP, and toxins. Very chronic, 2 years, 3 years, he is having neuropathy, diabetes, alcohol, hereditary neuropathies. You have to consider. Critical features of polyneuropathy. Length-dependent neuropathy. This is also called the dying back neuropathy. What will happen? The neuropathy starts in the toes and then it extends to the feet, then to the hands. Once it comes to the hands, the feet have recovered. They will recover and the neuropathy is not felt. This is called length-dependent or dying back neuropathy. It may be a short notes. So you may get a short notes called dying back neuropathy. Okay, slow and grow and stalking type of sensory loss, reflexes lost distally first. Distal reflexes are like ankle jerk and then the supinator jerk. These are lost first. Seen in diabetes, alcohol, and toxins. Non-length dependent neuropathy. Proximal involvement, early sensory loss is usually patchy. That means some part is normal, some part is affected. CIDP, vasculitis, inflammatory neuropathies. So, how do I examination? The favorite is differentiate motor and sensory neuropathy. They will ask differentiate motor and sensory neuropathy. How do I differentiate? GBS, motor symptoms very prominent. For example, GBS, CIDP, lead poisoning is also mononeuropathy. Motor neuropathy, lead poisoning is classical motor neuropathy. Sensory predominant diabetes and B12. Painful neuropathy, small fiber neuropathy. Because this is a positive sense neuropathy. Autoimmune autonomic symptoms are prominent. Diabetes and amyloidosis should be considered. So how do I differentiate motor from sensory? Motor, predominantly motor symptoms, GBS, CIDP, lead poisoning. Sensory predominant, diabetes and B12. Painful neuropathy, small fiber neuropathy. And then you have autonomic prominent diabetes and amyloidosis. Autonomic neuropathy. What are the red flags of autonomic neuropathy? Postural hypotension without dehydration. Normally, postural hypotension, the person is dehydrated, he will have postural hypotension. Here there is no dehydration, but he will have postural hypotension because of the autonomic failure there, autonomic neuropathy. And another thing, resting heart rate is usually above 100. If a person has got autonomic symptoms with a resting heart rate of more than 100, you should consider autonomic neuropathy. Erectile dysfunction, particularly many patients of diabetes, we have diagnosed using erectile dysfunction as the initial presentation. They come to you and say, Doctor, I am having problem with my erectile erection. And when we go deep and then do the blood test, we find they're diabetics. So they come up very early manifestation is erectile dysfunction. There is a paper by me, ED is equal to ED. Erectile dysfunction is equal to endocrine dysfunction. Endothelial dysfunction. Endothelial dysfunction is equal to erectile dysfunction. So silent myocardial ischemia also, autonomic neuropathy will be there. Common causes are diabetes, amyloidosis, Guillain-Barré, Parkinson plus syndromes. Then etiological classification. So many ways you can look at it. Metabolic, nutritional. Metabolic, diabetes most common worldwide, uremia, hypothyroidism also can produce entrapment neuropathy. Hypothyroidism ixomatous tissue will be deposited that can produce entrapment neuropathies. Nutritional deficiencies, B12, thiamine, and copper deficiency. Toxic, alcohol, chemotherapy with vincristine, cisplatin, heavy metal use like particularly arsenic, you can have neuropathy. Infections, HIV, leprosy, and diphtheria. Immune-mediated, GBS, CIDP, vasculitic type of neuropathy. Hereditary, Charcot-Marie-Tooth disease, familial amyloid polyneuropathy. These are the various types of hereditary, immune-mediated, infectious, toxic, nutritional, and metabolic as far as the etiology is concerned. So I am showing you etiological type, motor, sensory, and autonomic type, and the motor versus sensory. And I am also showing you the clinical pattern of neuropathy, large fiber versus small fiber. And we have also shown you the temporal profile, acute versus subacute and chronic. And we have also got the axon versus demyelination, pathophysiological classification. And you also have got the fiber type involvement, large fiber, small fiber like that. And you also have the pathological classification, depending on what type of degeneration. And you also have the anatomical classification, mono, multiplex versus the polyneuropathy. So several ways we can classify the polyneuropathy. Polyneuropathy may be an essay question also sometimes. So keep this file with you, and this is the way you are supposed to discuss the various neuropathy. Etiology also we have seen. Now, peripheral, the confusion always lingers in the PG's mind. Peripheral neuropathy, radiculopathy, myelopathy. What is radiculopathy?
Radicals.
Brachial plexus, sciatic plexus. So if the radicals are involved, roots are involved. So peripheral neuropathy versus radiculopathy versus cardpathy. Cardpathy is myelopathy, spinal cord. How do you distinguish? Very important table. Distribution. Peripheral neuropathy, distal and symmetric. Radiculopathy, dermatomal. Which particular radical is involved, that dermatome only you will get it. Myelopathy, there will be a level below which you will not have the sensations, sensory disturbances below a level. Reflexes, reduced in peripheral neuropathy, reduced in that particular route. Myelopathy, they are exaggerated because the upper motor neurons also are compressed in the myelopathy. So exaggerated reflexes, neuropathy, consider myelopathy. Reduced reflexes, neuropathy, distal symmetric, consider peripheral. Only dermatomal loss of the sensory field, radiculopathy. Bladder involvement, very late in peripheral neuropathy, very early in myelopathy, rather almost not there in radiculopathy. This is a very important table for you. Electrodiagnostic analysis. The gold standard is do an NCS study, nerve conduction study. How do I do that? Demyelinating pattern characterized by reduced conduction and prolonged distal latency. So, in demyelinating pattern, the conduction velocity is reduced and the distal latency is also observed. Axonal pattern, reduced amplitude and preserved conduction velocity. That is the most important difference. So, after seeing the report, if the amplitude is reduced and conduction is preserved, it is axonal. If the amplitude is unaffected, but the velocity is reduced and distal latency is there, it is demyelinating type of pattern. Okay. Now, mechanics of glove and stocking sensory loss. Why you get the glove and stocking type of sensory loss? What is the cause of that? That's what we have to see. Glove and stocking means there will be the palms and the dorsa are affected. Likewise, the sole and the foot are affected. So the pattern is the hallmark of length-dependent axonopathy, also called the dying back neuropathy. Length dependency principle. The fundamental cause is a failure of the neuron to maintain the metabolic requirements of its most distal axonal segment. What will happen? The axon is not properly nourished. When it is not properly nourished, the distal parts suffers. And when the nutrition comes slowly, the distal recovers and then creeps upward. Axonal transport. Neurons are the longest cells in the body. Some axons are sometimes 1 meter also. They rely on Keynesian and Keynesian movement, anterograde and Dynean retrograde motors to transport proteins, mitochondria, nutrients from the cell body, perikaryon to the synapse. So the axonal transport is both Keynesian and Dynean, and usually some axons are very large. Metabolic stress. Distal terminals are most vulnerable. Any systemic metabolic insult like hyperglycemia, toxins, or uremia affects the long axons first because they have the highest metabolic demand and most precarious supply chain. The longer the axon length, the more it is vulnerable for metabolic stress. So the uremia, diabetes, toxins, these affect the long fibers. This is called dying back neuropathy. Then clinical progression, the rule of halves. Feet. Symptoms typically begin in the toes and progress up to the feet. Symptoms typically begin in the toes and progress up to the feet. The transition to hands, as the sensory loss reaches the level of the mid calf or knees, the distal ends of the shorter axons in the upper limbs also begin to fail, starting to the fingertip. This is called the transition to the hands. And the result, by the time patient has got stocking anesthesia to the knees, they usually develop gloves. So what happens? First it starts in the lower limb, the longest axon. Then there will be stocking type of anesthesia will develop up to the knee joint. Then the small length will be there, the upper limb fibers. They start getting affected and then get the glove also. That is why the gloved stocking type of anesthesia. Anatomical basis of sensory involvement. Sensory fibers are usually affected before the motor fibers. Always it is the sensory fibers which are more affected, earlier affected than the and then the motor fibers. Most metabolic polyneuropathy, because fiber length, sensory neurons from the dorsal root ganglion have exceptionally long peripheral process. See, it has to start from the skin and go up to the dorsal root ganglion. So very long course is there. Lack of blood-brain barrier. The DRG, that is the dorsal root ganglion, the distal nerve terminals lack the tight endothelial junctions found in the CNS because these junctions are outside the CNS. Dorsal root ganglions are outside. Because of that, making them more susceptible to circulating toxins and metabolic fluctuations. Something is within the cranium or within the spinal cord, the toxins and metabolites cannot easily reach. They have to go only through the cerebrospinal. Whereas if the dorsal root ganglion outside, it can go through the bloodstream also. It can go from outside. Clinical application. Red flag signs. If the patient presents with glove starting symptoms, PG student look for the deviations from this pattern. Deviation from pattern, positional meaning. Proximal weakness more than the distal weakness. That means suggest a myopathy or an inflammatory demyelinating one. Normally what will happen? Distal is more affected than the proximal. In a neuropathy, distal involvement is more than the proximal. But if you see in the neuropathy, proximal is more than the distal, you should consider a myopathy or an inflammatory demyelinating disease like AIDP or CIDP, right? Then asymmetric involvement. Usually we see symmetric involvement in polyneuropathy. Asymmetric involvement such as mononeuritis multiplex or a vasculitis or a plexopathy, that is brachial plexus, sciatic plexus like that. Pure small fiber involvement. If you get pure small fiber involvement, such as diabetes, amyloidosis, idiopathic small fiber neuropathy. Mid-chest sensory level. If the stocking climbs to the region of the groin and then appears on the abdomen, suggests a tandem pathology or a severe progression involving the intercostal nerves. That means there may be an associated tandem pathology in the spinal cord also. What are the lab workups I do? Okay. The ability to link specific lab abnormalities to the neurological phenotype is a core competency. How do you understand which particular lab abnormality is related to which neuropathy? This table serves as a cheat sheet. That means without going into the depth, this table alone will be able to make you surmise this could be the reason. Okay, for the differential diagnosis. Lab clues in peripheral neuropathy. Okay. HbA1c and glucose, they are elevated. Hey, HbA1c, high fasting glucose. Diabetic polyneuropathy. Usually distal, usually symmetric, but can be diabetic amyotrophy. Proximal also can occur. Autonomic also can be combined. B12, subacute combined degeneration. B12 levels are low. Combined neuropathy with dorsal column loss and pyramidal signs. You will have two things. By combined, the dorsal columns are affected and the pyramidal signs are also there. That is motor symptoms and sensory symptoms together. But don't be satisfied with the only B12. You have to estimate what is called the B12. When the B12 functional B12 we have to estimate. That is the methylmalonic acid deficiency. Methylmalonic acid is MMA. So you have to measure the methyl malonic acid. Whenever you see the B12 deficiency, the B12 is borderline. Suppose a patient you are suspecting B12 deficiency, you do it, you don't find a gross B12 deficiency, then you do a MMA test, methyl malonic acid. Then monoclonal spikes will be there. What are monoclonal spikes? Paraproteinemia can be there in neuropathy, and then you can get the monoclonal gamma neuropathy. Gamma monoclonal neuropathy often presents as a chronic distal large fiber demyelinating neuropathy. Monoclonal neuropathies are large fiber. When we say large fiber, here it is not axonal, but it is the Schwann cells and the myelin sheath that is affected. CSF protein. So what is the other investigation? The first one investigation is diabetes. Second one is B12. Third one is MMA for early detection of B12 deficiency. Monoclonal spikes also you can see serum protein electrophoresis. CSF proteins and normal cells are normal, but protein only is elevated. GBS or chronic inflammatory demyelinating polyneuropathy. So, albuminocytological dissociation. What is that? Albuminocytological dissociation.
Cells and protein will be dealing
cerebrospinal fluid. Normally, you have more protein, you expect more cells. Here, protein is elevated, cells are not. That is called the AC dissociation. Points toward inflammatory demyelinating rather than infective. If it is an infection, the albumin will go up and also the cells will go up. In inflammatory type, the albumin will go up, protein, and the cells remain normal. Okay, serum creatinine, uremic neuropathy improves significantly following dialysis or renal transplant. You can also look for ALT, AST, and hepatitis C also. Cryoglobulinemia may be there, and vasculitis may be there. Often presents as mononeuritis, multiplex with purpura and arthralgia. So the investigations are, apart from the nerve conduction studies, can do HbA1c glucose, vitamin B12, methylmalonic acid, monoclonal gammopathy, CSF proteins, and then serum creatinine, liver function test, and serum ACE levels. So serum ACE levels are increased in sarcoidosis, can use cranial nerve palsy also. It can cause especially cranial nerve 7 or small fiber neuropathy. If somebody has got sarcoidosis and ACE levels are elevated, seventh nerve paralysis, it could be the cause. ESR, CRP, ANC, ANCA. ANCA this is again for the systemic vasculitis, systemic lupus erythematosus, ANCA. Okay, rapidly progressive, painful, symmetric motor and sensory loss. Anti-GQ1B antibodies. This is the Miller-Fisher syndrome, the triad of ataxia, areflexia, ophthalmoplegia. Somebody has got ataxia and dental jerks are absent, and ophthalmoplegia, the ophthalmic, that means the recti muscles also. You have paralysis, then that is called anti-GQ1B antibodies or Miller-Fisher syndrome. Anti-GM1 antibodies, multifocal motor neuron neuropathy, also called the MMN, purely motor, asymmetric weakness with conduction block. So these are the various tests that you do. What are the tests? Nerve conduction study. Nerve conduction study, the amplitude is reduced, velocity is normal. That is small fiber. If you have, that is axonal. When you have the myelin sheath is affected, distal latency is there, velocity is reduced, amplitude may or may not be affected. Laboratory testing, HbA1c and glucose for diabetes, B12 for subacute combined degeneration, methylmalonic acid for early B12 deficiency, monoclonal parameters for the paraproteinemia, CSF protein for ADIP or CIDIP. AIDIP is GBS, acute inflammatory demyelinating polyneuropathy or chronic inflammatory. There is a albuminocytological reversal will be there. Creatinine for uremic neuropathy, ALT, AST for cryoglobulinemia and vasculitis. and ANCA and serum AST levels, ANCA, CRP, ESR for vasculitis, and then AC levels are for the sarcoidosis. AC levels for sarcoidosis. So, anti-GQ1B, there will be a triad of ataxia, areflexia, and ophthalmoplegia. Anti-GM1 antibodies, purely motor, symmetric weakness with conduction blocks in the ANCs. So, what are the PERDs? B12 trap. What is that B12 trap? Do not rely on B12 levels alone. Approximately 10 to 15% of the people, patients with neuropsychiatric manifest symptoms of B12 deficiency have normal B12. Always check methylmalonic acid MMA. If MMA is elevated, the patient needs replacement regardless of the serum level. If the serum B12 is normal, don't be stopping short, do an MMA. MMA will be elevated. MMA is the metabolic precursor. So naturally, methylmalonic acid elevation is significant B12 deficiency. Significance of M spike. Suppose you see a protein electrophoresis and see an M spike. That is called monoclonal gammopathy of undetermined significance. MGUS, if the patient is 50 years old, I used to have a lady who came with severe neuropathy and she is around 60 years. When we did the serum protein electrophoresis, we found her to have the classical, what is that, bone tumor, bone malignancy with M protein, that is Bernstein protein and all that. Yes, multiple myeloma. She was a patient of multiple myeloma and she had a M spike very much and she presented with neuropathy. Then ultimately we could find out that the reason is MGUS, monoclonal gammopathy of undetermined significance. Polyneuropathy, organomegaly, endocrinopathy, monoclonal protein, skin changes, all these things will be there, and hematological changes also. Chronic inflammatory demyelinating polyradiculopathy, radiculoneuropathy, also called the CIDP. The labs are entirely normal in this patient, but the patient has proximal and distal with global areflexia. Diagnosis is likely. Both proximal are involved, distal are involved. If at all you do a CSF, these fellows will have albuminocytological reversal. This requires an NCS and DMG, shows demyelination and potentially a lumbar puncture for albuminocytological reversal. This is the CID. About how to approach bedside to a patient with polyneuropathy. Learned so much of theory, how can I translate into the bedside? First thing is the weakness distal or proximal? Distal means peripheral neuropathy. Proximal, it is chronic immunodeficiency, CIDP or EIDP. Proximal, is it symmetrical? Usually common nutritional or diabetic polyneuropathy. Asymmetrical, one of these things. Is sensory loss present? That is sensory neuropathy. Reflexes are reduced. That is proprioceptive receptors are affected. Long fiber. Autonomic features are there. Diabetic autonomic neuropathy. Acute or chronic. Acute Guillain-Barré. Chronic diabetes, alcohol, toxins. Axonal or demyelinating. Axonal conduction is normal, amplitude is reduced. Demyelinating conduction is the hallmark, conduction is reduced, distal latency is seen, and the amplitude may or may not be reduced. Demyelinating usually any one of the autoimmune diseases or demyelinating syndromes. This approach narrows the diagnosis before investigation. So what are the investigators? Already we told. B12, HbA1c, blood glucose, folate, TSH because entrapment neuropathy, liver and renal function, and also do the serum protein electrophoresis also add there. Electrophysiology, NCS and EMG. EMG for myopathies, NCS for the neuropathies. Axonal versus demyelinating. I told you 3 times how to differentiate between them. Helps to differentiate neuropathy from myopathy. What are the special tests? CSF protein and cells, GBS and CIDP. nerve biopsy is for amyloidosis and vasculitis, and then you have skin biopsy, small fiber neuropathy, and genetic testing, particularly if you are suspecting hereditary polyneuropathy. Common exam scenarios. You see, patient is having burning feet, normal reflexes, normal nerve conduction study. Means small fiber neuropathy. Symmetrical distal sensory loss, absent deep tendon reflex, long duration, diabetic polyneuropathy. Because tendon jerks are lost early and it is symmetric and distal. Case 3. Rapidly ascending weakness, areflexia, minimal sensory involvement, Guillain-Barré. Okay. So you remember like that. Somebody has got positive sensory symptoms like pain, burning feet, this normal reflexes, and then shock-like sensations, small fiber neuropathy. The nerve conduction studies will be normal. And symmetrical distal sensory loss, reflexes are affected, long duration of diabetes, diabetic polyneuropathy. Somebody has got ascending weakness, areflexia is there, no sensory loss or minimal sensory loss. Guillain-Barré you can see. Okay? One line summary. Peripheral neuropathy is a disorder of peripheral nerves classified by the fiber type, distribution, pathology, temporal profile. Systematic clinical analysis allows accurate localization and etiological diagnosis before investigations. Teaching pearls: if reflexes are preserved, think small fiber disease. If weakness is proximal, think demyelination. If the pattern is asymmetric, think vasculitis. Very easy. Okay. So last 3-4 slides are very important for you. I'm going to repeat those things. So from here, bedside approach to a patient with polyneuropathy. What do I do? Where is my bottle? So when a patient comes with neuropathy, how do I go about? Is the weakness distal or proximal? Proximal means what? Proximal weakness is usually autoimmune or some other thing. Distal is usually peripheral or nutritional. Is it symmetric or asymmetric? Usually peripheral neuropathy is symmetric. Is it sensory or is there sensory loss also or there? If it is pure, it is Guillain-Barré, pure motor. Sensory is also there, unlikely to be Guillain-Barré. Reflexes are reduced. Reflexes are reduced in long fiber neuron. This one. Small fiber one, reflexes are preserved. Autonomic features are there, favors diabetes. Acute versus chronic. Acute is Guillain-Barré, toxins, and chronic, of course, is your diabetes, alcohol, toxins. Axonal or demyelinating. Axonal, how do I know? Nerve conduction is normal, amplitude is reduced. Demyelinating, conduction is the hallmark, and distal latency will be there. Amplitude may or may not be disturbed. This approach narrows the diagnostic investigation. Now, what do you go to do this? Baseline investigations are blood glucose, hemoglobin A1C, blood glucose, hemoglobin A1C, B12, folate, TSH for entrapment neuropathy, renal and liver function, and special tests include NCS and EMG. EMG to exclude myopathies, NCS to see whether it is axonal or myelin. Axonal conduction is affected and the conduction is not affected, only the amplitude is reduced. Whereas myelin, the conduction is the hallmark, conduction is affected and amplitude may or may not be reduced. Distal latency will be there. Then special test, CSF for albuminocytological reversal in acute IDP, that is Guillain-Barré. Chronic IDP, it also can be due to chronic inflammatory demyelinating polyneuropathy. Nerve biopsy, if you are suspecting vasculitis, nerve biopsy, endomyelitis. Skin biopsy, small fiber neuropathy. Particularly in leprosy also, skin biopsy may be useful. Genetic testing, if you are suspecting hereditary neuropathies, like Charcot-Marie tooth or something like that. Common exam scenarios. Patient comes with, he will ask you in VOC. A patient has got neuropathy, he has got burning feet, positive symptoms, reflexes are normal, nerve conduction studies are normal. What could be your diagnosis? Small fiber neuropathy. The other way around, there's a symmetric distal sensory loss, have absence, reflexes are absent, long duration of diabetes is there, diabetic polyneuropathy. Ascending weakness, areflexia, minimal sensory loss, Guillain-Barré. Okay? Peripheral neuropathy is a disorder of the peripheral nerves. There is no CNS involvement, no cord involvement, no myoneural junction involvement, no muscle involvement also. Okay? That is the myopathy is there. It's a classified by fiber type, distribution, pathology, temporal profile, systemic clinical analysis. The analysis shows accurate localization and etiological diagnosis. General pearls are reflexes preserved, think small fiber disease. Proximal weakness is more compared to distal weakness, demyelinating diseases, either AIDP or CIDP. If pattern is asymmetric, think of vasculitis. If reflexes are lost, think of long fiber disease. Okay? This is the summary. This I'm going to share with you. The other two students have missed a very interesting and beautiful class on peripheral neuropathy. Nobody would have put so many ways of looking at peripheral neuropathy this way. I will share the PDF to you. Next week, we are going to see diabetic polyneuropathy. Specifically, this is a very important condition clinically and practice-wise also. So, diabetic polyneuropathy itself is a separate entity. So, we need to look at that separately. The management parents also are there. So, there's no time for that today. I thought both I will do. But, we will do the diabetic polyneuropathy separately. Peripheral neuropathy is good enough now, anatomical, functional, the long fiber, short fiber, demyelination, axonal, pathological type of classifications, acute, chronic, and so many ways we have classified and also looked at the various signs, tests required to diagnose the disease, and then also the pearls for, So what are the pearls? I'll ask you now. A patient has come with positive sensory symptoms. Means positive sensory symptoms is burning, dysesthesia, allodynia, and then he has got shock-like sensations. It is small fiber. A patient has got negative sensory symptoms, which are symmetric, and then the amplitude is reduced, nerve conduction is normal. That is a long fiber. Patient is a chronic diabetic, but symmetric, motor as well as sensory, may have also autonomic features, suggest diabetes. A patient has got no sensory, but only ascending motor neuropathy with areflexia, Guillain-Barré syndrome. A patient has got more of proximal weakness compared to distal weakness. It is something like a demyelinating disorder. Okay? So this is the point. So how you differentiate how do you differentiate between a demyelinating one from a small fiber? Demyelinating one, proximal neuropathy. Here it is the distal neuropathy here. Small fiber neuropathy, positive sensory. Long tract, the proprioception is affected, areflexia is that long fiber. Where because of the parent temperature is not disturbed much, but the ataxia, proprioception. Rare syndromes are there, but basically these things you must understand. So with this, we will stop here.